Okay, so here are some of the main things for the kidneys. The main thing to know is that the kidneys are highly affected by changes to perfusion. Your kidneys will, like it says here, receive 20 to 25% of your cardiac output. So they very much are one of the things that get affected when your perfusion's bad. If you're dehydrated, your kidneys get affected. If you have issues with your heart, your kidneys get affected. So when it comes to perfusion issues, the kidneys are something that you always got to consider, because it's always possible for someone with these perfusion issues to then develop kidney issues. And if they're there for heart issues, you don't want them to also have a kidney issue develop, because that definitely does happen. Uh, and it's very important to kind of keep note of that. And so that's why keeping note of their hydration, how good that's going, keeping track of their urine output is something that is good to do. So like whenever you have the ability to do so, keeping track of how much is coming out is a good idea. Keeping track of some of their labs is a good idea. Uh, just prevent acute kidney injuries and things like that, which we'll go over. Mhm. Something else that I wanted to bring up is something called hepatorenal syndrome. It's essentially impairment of the kidney that results from severe liver disease. So this is a concept that will come back again when you guys go over liver, but there is a correlation there, believed to happen due to people with severe liver issues. There have issues with the perfusion going to that area. So they have what's called the portal vein, and that can have hypertension due to just poor perfusion to that area, issues with the liver, and like I mentioned, anything that affects perfusion really has an impact on the kidneys. So it is not uncommon for those with really bad liver issues, liver cirrhosis, um, NASH, all that stuff, history of alcoholism, history of hepatitis, all that stuff, to have also issues with their kidneys. Okay, so something I have here as well is kind of protecting the kidneys, managing their hypertension. That's perfusion, managing their diabetes. Uh, it's just important to remember diabetes is not just glucose regulation. It affects perfusion. It affects infection risk, it affects healing, it affects nerve pain, it affects your vision, which is why you really don't want to be diabetic. So managing your diet is very important. Managing your stress can also be very important. I have been pre-diabetic due to stress before during nursing school. One of my coworkers, like literally just 2 days ago, told us he's pre-diabetic because of stress. So stuff like that happens. Hyperlipidemia, so your diet, very important. Genetics can also play a part into it. Uh, and then alcohol and smoking, just in general, very often, if one of your answer choices for something is avoid or restrict alcohol or smoking, that's probably the right answer. Yeah, both of those just have a lot of big impact on your general health. Smoking also is a vasoconstrictor, so that will affect your perfusion. Alcohol has an effect on your glucose regulation. It has effect on your liver, so that kind of all leads back to that. So some of the main functions of the kidneys, we know that the kidneys help to regulate some of the volume. They went over the RAS system at some point, leading to the release of aldosterone. The release of aldosterone then retains sodium, and water follows sodium. So it leads to the retainment of water. And something that's easy to forget is that aldosterone also leads to the retention of potassium, which you can kind of apply with the kind of knowledge that like uh, ACE inhibitors like lisinopril and those kind of things, they have an effect on the RAS system. And one of the things that you watch out for with lisinoprils, or with lisinopril and all the other prils and the sartans, is that they increase potassium. So the idea here, if you're blocking the release of aldosterone, then you're no longer retaining sodium and releasing potassium. You're now having um, the opposite occur. So you are not retaining you're not retaining sodium, but you're also not releasing excess potassium, which is why there's that buildup of potassium with with the prils and the sardines. Okay. The kidneys also help to reabsorb water and electrolytes or move them as needed through the urine. So that's why your urine output's important. If you're not able to get out enough urine, then you're not getting rid of enough of whatever waste products are being built up. So some of the things that's good to remember: when the kidneys are abnormal, you can have low urinary output, but it's worth keeping in mind that um, someone with kidney issues doesn't necessarily not make urine. And this will be especially the case with like the end stage renal disease. Not everybody that is end stage renal disease or has a really advanced chronic kidney disease will necessarily be anuric. Anuric meaning they don't make urine. So it's something that's important to ask. Something that's very important to ask your patient because they're gonna know. Something that's very important to ask your patient just so that you're able to establish a baseline. So it's like maybe you have a patient with advanced stage renal disease. You made the assumption that they don't make urine without asking. And so when if your floor does strict eyes and nose, you notice that they don't make urine, you're like, yeah, that's fine. Yeah, that's fine. But then later it turns out it was actually the beginning of maybe like hypovolemic shock or something like that. Because that is one of the early signs of hypovolemic shock is just is decreased output. So that's why it's important to ask. When your kidneys are abnormal, of course, uh, fluid volume overload occurs because you're not able to get rid of some of your water and waste products, and then acid-base imbalance as well. If you guys recall from last week, your acid base is also affected by your kidneys. They are the more effective one at managing it, at affecting it, because it helps to release, helps to either retain or get rid of excess bicarbonate. If your kidneys aren't working, then there's going to be issues with that. Another way that your kidneys affect your volume is through antidiuretic hormone. So the antidiuretic hormone affects the kidneys and then it tells the kidneys to reabsorb more water. So part in the name, antidiuretic, that means you're doing the opposite of diuretic, you're retaining water. And your kidneys play a role in that. So later on, you guys will learn about some of the diseases that are impacted by ADH, where your body, maybe your kidneys don't respond to the antidiuretic hormone, so they're not able to reabsorb water, and then you're just passing everything through. And you might have heard of this before. That one is called diabetes insipidus. And like I mentioned, reabsorb water and electrolytes as needed. Uh, the the goal of urine is to be a way for you to waste your waste. drugs, which is why we do drug tests with the urine, electrolytes. So as your kidney function decreases, you're gonna have a buildup of urea. Uh, if you guys recall, BUN is blood urea nitrogen. So that is the amount of nitrogen, urea nitrogen that is in your blood because it's not being excreted properly by your kidneys. So this is something that can build up when your kidneys are impaired, or it could also just be from dehydration because if you're dehydrated, you're not making enough urine and you're not getting rid of BUN, your urea nitrogen as well as it should, which is why it builds up in the blood. So for that reason, some of the nuance when it comes to the kidney labs includes kind of knowing that creatinine is a bit of a better indicator for full-on kidney impairment, as well as your creatinine clearance rate. And then your BUN is something else that can be looked at, especially when you take into account a ratio, and we'll talk about that later. Uh, but it's also an indicator of dehydration as well. So if you have a patient with increased BUN and normal creatinine, it could just be a sign that they're dehydrated. They need water. Yeah, and if your kidney function's not working, electrolyte imbalances play into account, and that's a very big part of this chapter or this topic. And then drug toxicity. So, in general, when your kidneys or your liver are not working properly, drug toxicity is something that gets taken into account. If you've ever had a patient with kidney issues, you might have heard of renal dosing. So they do a creatinine clearance rate to see how well their kidneys are actually filtering things out, and then they are have their medication doses adjusted accordingly. Okay, so this is part of where the interactive portion is here. Uh, your kidneys regulate electrolytes, so they get rid of some of that through the urine or through reabsorption. So some of these they will be reabsorbed when they come by the kidney tubules, the loop of Henle, etc. So, what do you guys know about the effects of potassium with impaired kidneys? Does it go up or does it go down?
It goes up.
Yeah, so it does go up. So potassium is gonna go up. So that's let's just say up hyperkalemia. Oh, hyperkalemia. Okay. And then we'll kind of go over each one individually later, but we'll just kind of do a full scoop for now. Does anyone know what goes on with the phosphate?
Up.
Hmm. So we have hyperphosphatemia. What about magnesium?
I think it goes up. I'm not sure.
Yeah, so this one goes up as well. Magnesium, yeah. And then what about calcium and sodium? Pair them together because they both go the same direction.
They go down.
They go down, yeah. So we have hypocalcemia and we have hyponatremia. Not sure where that one immediately came. Hold, wherever. Okay, so we'll go over each one then from top to bottom. So if your kidneys aren't working too well, your potassium is not being expelled like it should. So that's why it builds up. Same thing with your phosphate and same thing with your magnesium. The reason for why your calcium and sodium go down, what do you guys know about it? Like, why does it go down instead of up like the other ones?
Doesn't sodium and potassium have an inverse relationship? Same thing with calcium and phosphate.
For the sodium, that's part of it. Yes, the calcium is and then for the calcium, that's definitely the biggest reason is that the calcium has an inverse relationship with your phosphate. So phosphate being really high has an impact on your calcium. It's going to go down because of the high potassium. Another reason that is really extra, you really don't have to know too much about it, is that your kidneys are also in charge of activating your vitamin D. So what your vitamin D does is help improve absorption of calcium. So if your vitamin D is lower because your kidneys aren't working properly and activating it, your absorption of calcium is also going to be lower. And then um, the thing with sodium is that if you guys recall, is sodium more prevalent outside or inside of the cells? Yeah, so it's outside of the cell, so it is actually more affected by fluid changes. So this sodium is low because of like you guys can kind of make the assumption here if it's affected more by fluid imbalances and your kidneys, like we mentioned previously, leads to fluid volume overload, then you're having dilutional hyponatremia. You have so much fluid overload that it is affecting your sodium. The other ones are not as affected by the fluid volume overload as much, because most of these um, are more focused inside of the cell, so they don't get diluted the same way. Hence why when you guys went over fluid electrolytes, there was talks about dilutional hyponatremia, hypervolemic hyponatremia, but there was not really the same with the potassium. Okay. Do you guys remember what your potassium normal value is? 3.5 to 5, correct? What about your sodium? What's your sodium normal value? 35 to 145, correct? I don't think they test on the other ones, the other electrolyte values, like hard memorization. So I wouldn't worry about that personally. Um, so now instead what we're gonna do is we're gonna just kind of look at some of the signs and symptoms of these electrolyte imbalances. So what do you guys know about high potassium and how it affects the body? Yeah, it's gonna be a lot of your heart. So your arrhythmias. What about other things that arrhythmia is gonna be like one of the main ones. How else can it affect the general body? Think about the idea that we operate with a sodium potassium pump. The sodium potassium pump is utilized for like muscle movement and stuff. Mm, So not so much increase on the DTR, the your deep tendon reflexes. So with hyperkalemia, if you guys recall, it has an effect on your muscles. So it leads to muscle weakness and muscle twitching, things like that. So I believe you would have the opposite of instead of like an increase in your reflexes in your deep tendon reflexes, you would have like a decrease because of less excitability with that whole like potassium sodium pump. So less of that. So main thing I was kind of getting at is just the muscle weakness, maybe muscle twitching, and something to keep note of is that when you have weakness, so one of your muscles is the diaphragm. When you have weakness in that muscle, you're also going to have difficulty possibly breathing. So, although this is probably for more severe cases, but that's the general idea to kind of consider for that. Um, Pretty much that. For phosphate, I know they don't go over it so much. The main thing I will kind of write down for you guys is just let's see. Main thing I'll write down is just when it comes to phosphate and magnesium, also basically just think of arrhythmias. So risk of arrhythmias. I always spell that word wrong. And like we mentioned, it has an opposite relationship with calcium. So increase phosphate, decrease calcium. Magnesium, again, when it's high, think of it as arrhythmias again. I always spell it wrong. There we go. And then hypocalcemia, we mentioned, is decreased due to high phosphate, lack of activation of vitamin D, which I briefly mentioned, not as important. Don't worry about that too much. And then some of the things to consider is just low calcium could lead to bone pain or pathological fractures. But it's also worth something that is worth noting as well is that your calcium blood lab doesn't necessarily mean that they have a low amount of biologically available calcium, and that sounds really extra, I know. I don't know if anybody has ever heard of like a corrected calcium. I don't know if that's ever come up at all during clinicals or anything. It's kind of extra. It's more like a nephrology type thing, but the idea of that is that you could have someone with a blood work of calcium that's lower than what the normal number is, but you won't see any supplementation. You might not see supplementation unless they're straight up like full-on kidney patients, uh, because sometimes that number is affected by the albumin. So again, this is kind of extra. You really don't have to know this. But if it does come up, you can look really smart, I suppose, in front of your teacher. So right here is what I got for you guys. So when you get a BMP, like your metabolic panel, It will assess the overall concentration of calcium in blood, uh, regardless if it is your biologically active amount versus just your free amount. So that number on the BNP includes calcium that is actively ready for use by your body and the calcium that is hanging out as a reserve. So um, your calcium in the blood exists as either active or in reserve, and when it's in reserve, it's bound to albumin. So the idea of this calculation is that if someone has low albumin levels, which could be a cause of like malnutrition or anything like that, there is a formula to determine whether their actual uh if they're actually they have actual hypocalcemia. So not just from the number on the BNP, but from this formula to see if the affected to see if the albumin is actually affecting the calcium. So the idea would be that the albumin has an effect on the calcium. So if you have both the calcium and the albumin, you would take your calcium number and add it to this formula. So you would take 4 minus whatever your albumin is, multiply that by 0.8, and then add that to calcium. And if your number after doing that is still in the normal range, then even though their BMP calcium is low, they don't necessarily need correction because their available calcium that their body actually uses is still fine. And what went down is some of their reserve, if that makes sense. But again, I don't think this will come up for testing, but it might come up in clinical, I suppose. If you have a kidney patient, that could come up. But the main thing to really take into account with the low calcium, let me see if I have a picture of it. This one's a good one. I don't know if they've gone over this with you guys, but it's gonna just be a picture right here. Let's see if we can. It's kind of big, I guess. Have they ever gone over this? So this is something you might see on like a Kaplan, something you might see on testing. So some of the signs of hypocalcemia, like actual true hypocalcemia, would be what they call Fostek's sign. The CH is silent for some reason. Tapping that front nerve will cause twitching. And then Trousseau sign, which when you're taking their blood pressure, like above the systolic, it will cause some hand spasms. Okay. So this is terminology that you could see on a test, on a Kaplan, maybe on the NCLEX. But yeah. Any questions on anything so far? And let me know if this explanation was confusing, because I know you probably haven't gone over that at all on the corrected calcium. Okay. And then your sodium here. So we mentioned this is dilutional due to fluid volume overload. We set the normal range as this, and then I'll include some signs of hyponatremia. What do you guys remember about hyponatremia? What are some of like the key things that you guys recall?
Would you have like headache, confusion, or like A-lock?
Yeah, so you do have a lot of that as well. So they say that when you have really bad hyponatremia, you get like stroke-like symptoms. So, like altered level of consciousness, neurological deficits. You can have seizures when it's really low. And then also don't forget about like the weakness and muscle cramping. Just because remember like anything like the sodium potassium pump, that's how your muscles kind of get around. So if there's a low amount of that, it has an impact on how your muscles move, whether they're cramping, they're having muscle spasms. So just keep that in mind. Just potassium, sodium, when they're altered, you can have muscle weakness or cramping, muscle twitching as well. So that's just something to kind of keep in mind. And then specifically unique to sodium is the ability to get seizures and stroke-like deficits. So I have this little thing here. When you guys go over some exemplars for some of the endocrine conditions, they'll probably go into a bit more detail with like what happens at super low sodium levels. But the general concept is that your sodium is one of the main regulators of your fluid-based balance. Because if you guys recall, your water follows your solute, it's going to follow your salt. So if you have a low amount of salt outside of the cell, you start having movements in fluids. Those fluids can then go inside of the cells. And the idea is that when it's really low, you start having kind of movement of fluids into your brain cells, which can lead to those. And that's the reason for that altered level of consciousness, the ALOC, neurological deficits, and then the risk of seizures as well. Okay. But that I would say that's like the main thing I would really focus on is just the potassium and sodium, kind of like that they've been doing. But also just keep it in the back of your head how most of these electrolytes are causing arrhythmias. Your calcium can also lead to arrhythmias when it's altered, but also keep in mind for calcium some of these signs that you might see in literature testing. Okay. Like we mentioned, your kidneys also have an impact on your acid base, so get rid of some of the H plus, the hydrogen ions, get rid of that or reabsorb whatever is needed. Same thing with the bicarbonate. So when it's impaired, you have that risk of acidosis. And something else that's very common to see with the kidney patients is that they will have chronic anemia. Your kidneys help to release something called erythropoietin. This will help to stimulate the red bone marrow to make more red blood cells. So if your kidneys are impaired, you're not making enough of that, which means you're not making enough red blood cells, which is why you'll have chronic anemia. So sometimes the kidney patients, they will, instead of outright getting full-on blood transfusion, they will start with some synthetic erythropoietin. Um, both for the fact that part of the reason they're anemic is due to the lack of this this hormone, and also due to the fact that because they have kidney issues, they have fluid imbalances, they have fluid volume overload, so giving them too much blood can lead to worsening of the overload. So that's something you have to be kind of careful of with blood transfusions on people with kidney disease and heart failure. Could um they could go into overload. So that's something that I'm not sure when you guys go over blood transfusions and stuff, but that's something to keep in mind for that. I believe that one's called a taco. Uh, taco. That's transfusion associated circulatory overload. So that's one of the possible things that could happen to your heart failure or kidney patients if they're getting blood too quickly, et cetera, et cetera. I do like that it's called a taco. So that's why I remember that one. Okay. Um, so then we're talking about some diagnostics. So this one's completely blank because I want you guys to kind of through clinicals, anything that comes to mind when it comes to kidneys, like what are you looking at? What are some labs? What are some diagnostics that can be done for it? Yeah, so everything you guys have mentioned has been completely correct. So we have the BUN, we have the creatinine clearance, GFR. We have generally, yeah, they'll look at the electrolytes, so the from the BMP, the RBC, um, the H&H. So we can kind of include that like do a complete metabolic panel, BUN, creatinine, GFR, electrolytes, CBC, H&H, urine specific gravity, like a UA, urine specific gravity. Okay, yeah, the MAP as well. Perfect. What else you guys mentioned? Electrolytes. You guys mentioned literally everything. That's 24-hour urine. Yeah, that's good. Yeah, you guys mentioned literally everything. Yeah, cool. An ABG. If there's like acid-base imbalance, you could do that, I suppose. Yeah, it's not like the first line, but it's something you can definitely do if they're suspecting some acid-base balance irregularities. Something else maybe you've seen. They call it a KUB. It's literally just a CT scan of specifically the kidneys, ureters, and the bladder. It's literally just a CT scan, but it comes with a fancy name. So I'll add some more info here. So the BUN depends on the facility, what numbers are. It's like approximately 10 to 20 for normal number. We talked about how it's more determinative of hydration, determinative of hydration. The creatinine, again, different numbers everywhere you go. 0.7 to 1.1 is what I see a lot. More indicative of kidney function. Your GFR, I mentioned the creatinine clearance right here. Probably a little bit closer up. So something that's a little bit confusing is like what is a GFR versus a creatinine clearance? So in your CMP, your metabolic panel, you might have noticed that the GFR usually is actually there as a eGFR. So this one, the eGFR is an estimate. The E stands for estimate. So it's an estimated glomerular filtration rate. So it's an estimate, and usually you'll see it on there. Usually it won't give you like a straight up number. It might just be along the lines of like greater than 60 or greater than 90 or greater than 125, um, things like that. Instead of giving you a full number, like we said, that's like a full on estimate. So that would be normal is this much, but the GFR, the eGFR, is an estimate of your GFR, which is more closely aligned with your creatinine clearance. So your creatinine clearance, you'll see it listed usually as like CRCL, creatinine clearance. This is your actual GFR essentially, and the one you see on a BMP is like an estimate, but still same value. But just wanted to kind of point that out because there might be some confusion about that. And like we mentioned, the 24-hour urine, that's how you measure the creatinine clearance. So they would do a 24-hour urine collection. And something else, like an extra fact, just when you're doing that, you discard the first void and then collect it from there on out for 24 hours. But that collection of urine for 24 hours, they will see how much creatinine is being excreted out and then kind of make that calculation for this. And that would be the true GFR, otherwise known as creatinine clearance. Okay. And yeah, the reason why your creatinine more indicative of kidney function is because your kidney, it is a waste product. Creatinine is a waste product that your body has zero use, there's no use for. So it tries its absolute best to get rid of it. It will do its absolute best to get rid of it up until its last little nephron uh, is working. So when that creatinine is affected and is abnormal, that is a sign that your kidneys are really, really struggling because your kidneys will be going out of their way to clear that creatinine if possible. Meanwhile, your BUN is a lot more sensitive, hence why it's not the best indicator of kidney function, and we can use it a bit better for hydration. So for example, if you're a little bit fluid depleted, your creatinine isn't really going to go up too much because your kidneys are still doing their best to get rid of it as much as possible, but your BUN can go up because that urine's going to be pretty dark because it's going to be a low amount of fluid, a lot of waste, and then some of that waste backs up into the blood because you're not able to get rid of it. Okay. For the CBC, we talked about how we should look at the H&H because that's an indicator of fluid balance, and then anemia. So anemia and then fluid balance. Okay. Do you guys remember H&H up or down? Which one's dehydration? So whether having a high or low hematocrit would be dehydration. It would be increased. Yeah. So this one's a little bit kind of tough because you have that dehydration, that fluid volume. Well, actually, I guess it's different because I'm thinking this is overload. So they have overload. Sorry. So they have overload. So dehydration is probably the one we go over the most with the H&H. So we know that one would be increased because you're hemo concentrated. While with the kidneys, you are fluid volume overloaded, so the H&H goes lower because you're hemodiluted, which is makes sense because you're hemodiluted with the sodium, hence why the sodium goes down. And you're also anemic, so that number is also going to go down. Increased is fluid volume overload or anemia. Okay. Something else. It's not really a lab, but it's something calculated. It's just your urine output. Do you guys know what your minimal urine output is supposed to be? Yeah, so we have these two values and they're different as you can see, but they're both valid. So we're going with both here. So the 30 mLs per hour, that's kind of calculations from the urine output. So you would take a few hours of urine production and then calculate how much they've been producing an hour. For that one, I would say you want more closer to a little bit closer to like 60 ml per hour, though 30 is doable, but you want around 60 ml per hour. That's kind of like a little bit better. And then for your big calculation there, the 1 ml per kilogram per hour, that one's technically a bit more accurate. Because that one's weight based, so different weights are gonna create different amounts of urine. And then the absolute minimal for an adult is 0.5, but as closer to 1 as possible. So it's kind of similar to this. So you can work on a 30, but you want to get closer to 60. So similar idea here. You can work on a 0.5, but you'd rather be at a 1, and that's ml per kilogram per hour. Does that make sense? So same idea basically between these two. You guys can see it's literally half of this, but it's better to be here. But you can operate on here. And then all of this kind of leads out to an approximate 400 ml per day minimal. And I think this one's the one they really want you to focus on. This one is something that it's probably drilled into your head a bit by now for the urine output. Okay, and then let's talk about the MAP, the map. What is the minimal? What is the minimal, and then how do you calculate it? And if they haven't gone over it, I'll go over it with you guys. Yeah, that is exactly correct. So 60 to 70 minimal, and then yeah, diastolic times 2 at the systolic, and then divide everything by 3. So doing perfect here. We're gonna go here. And 60, 70 is the minimal, but then they also don't want too much. So up to 110 is ideal. As soon as you start getting under 60, the kidneys are really struggling to keep up. Your perfusion is starting to be affected. And then that's when you start having your issues and have that potential ability to go into an acute kidney injury, which is your exemplars. But I felt like you definitely needed the context of everything else behind here to kind of make it make sense. But yeah, this is something that you will probably calculate on tests, and they will probably not provide this number for you or this formula for you, so you do have to memorize it. So again, that is 2 times your diastolic, add your systolic, and then divide it all by 3. So let's do some example ones. So let's just do the classic standard 180 120 over 80, and try the formula and tell me what the MAP is. Yeah, like around 93.3. So that passes that minimal test. It's not too high, so that's good. So now let's take a look at a blood pressure that's a little bit worse. So let's try 80, 84 over 52. hmm So you see that this is starting to get close to the minimal amount that you need. And obviously this is a blood pressure that's showing that this person is about to crash out or crash, not crash out. They might, I don't think they have the energy to crash out. Mhm. So yeah, you can kind of see that. So um, and it makes sense, right? If they're having if they're starting to go into hypovolemic shock, or they're in the first stages of hypovolemic shock, their perfusion's not going to be great. Their kidneys are going to get affected, um, and stuff like that. So kind of makes sense. And I've seen, ICU people make jokes about the MAP because they'll have people with like severely, like just crazy, weird blood pressures, but they'll be like, they're hemodynamically stable because their MAP is fine. Let me see if I can get like a funny number. Oop, Um, I think I've seen. s- Well, if I can't find one, it's fine. So an example, I guess, kind of the opposite direction. 80 over 50. 80 over 50 is obviously not a good blood pressure, but if you see the MAP, it comes out to exactly 60. So that's um that's kind of funny. In the ICU, they'll be like, "This is fine. They got the drips going. Everything's good." I think I seen like a picture of someone on my thing with like 200 over like 70 or something blood pressure, and then technically the MAP is like technically above 760 to 70. And then and so they're like they're fine. But yeah, so there's a lot of nuance to it, but that's the general idea behind it. Any questions on anything so far? And then we'll go over acute kidney injury, your actual exemplars. I know it took a while to get here, but I think the context is important, and then the rest should be a lot faster, I believe. Okay. So the definition of an AKI, it used to be called an ARF or an ARF, an acute renal failure. It is the rapid decrease in kidney function, which the prognosis could either be good or bad depending on how far it's gone, how soon interventions are implemented. So you could have someone have an AKI and then make a full recovery, no long-term deficits, or you can have someone have an AKI and then it becomes chronic kidney disease because they've caused permanent damage. And I have seen it in the hospital where I had a patient with chronic kidney disease. I think they were stage 2, and then I come back 2 weeks later. I get assigned the same patient. He's still there, and I look at their chart. I just last thing I remembered was before I was gonna leave my clinical 2 weeks before I came back. He was gonna get a thoracentesis to get some fluid drained out of his pleural space. And then when I came back, I saw that one, they did the thoracentesis and they accidentally poked the lung, so he had a pneumothorax. Then he had an AKI, and then the AKI led his chronic kidney disease go from stage 2 to end stage. So and now he gets dialysis. So all of this happened in the span of 2 weeks. All I remember was the nurse I was assigned to telling me not to touch the urine output. He was gonna do it, so I'm not gonna say nothing, but that's all I'm gonna say. Something bad happened there. Clearly, the patient wasn't. I mean, the patient. Just, that I guess that's why it's important to kind of see how well hydrated they are, and it's a tough balance. I'm not gonna say it's not, but it's just kind of things like that. Especially because the patient here was nonverbal, so those patients, uh, people will just kind of ignore them because they don't talk. So they're easier to ignore and therefore they will be ignored. And things like this can happen because they're not there to complain. They're not able to complain the same way. So just kind of be careful with that. But some of the ways that you could get in it could lead to an AKI. They call it there's a few different types. So there's a pre-renal, an intrarenal, and a post-renal. So a pre-renal, kind of what it sounds like. It's an AKI before it really starts to affect the actual inside of the kidneys, before it really gets to the kidneys and really causes permanent damage to the nephrons. Intrarenal, intra meaning in between. So this is when it's that that decrease in perfusion is really affecting the inside of the kidneys, permanent damage to the nephrons. But then post-renal, post being like beyond. So this is more uh not directly related to the kidneys or perfusion directly. So with the pre-renal, you have what at the time, I don't know if you guys if this lecture is done by Miss Brooks, but for us it was done by Miss Brooks, and she called it the three H's: hypovolemia, hypoperfusion, and hypotension. These are some of the things that can lead to that, to pre-renal AKI. And the thing about it is that it's easy to just kind of look at these and be like, these are all the same thing. These are basically the same thing. Technically not, but I think it's important to not hyper focus on the exact difference between the three, but just know that the general concept of these three can lead to the pre-renal AKI. So don't hyper focus on the difference between hypoperfusion versus hypotension versus hypovolemia. Just mainly focus on the big picture rather than the small details for this. So hypovolemia, I'll just list some of the examples here. So anything that can lead to hypovolemic or hemorrhagic shock. So that would be a lack of fluids, lack of blood, getting rid of too much fluids. So trauma, losing blood; diuretics, losing fluids; dehydration, loss of fluids; polyuria, getting rid of a lot of fluids. So think about your DKA, your HHNS, your diabetes insipidus, like I mentioned before. So a lot of fluid loss, which makes sense. Your kidneys need fluids, your kidneys like fluids, your kidneys like all of that going on, or else they don't function as well. So a loss of a ton of fluids, hypovolemia, that can lead to an acute kidney injury. Um, and then hypoperfusion. This one, you want to think of it like decrease in cardiac output, so stuff that can affect your heart. So your infarction, your MIs, your heart failure, any sort of heart defect, anything wrong with your valves could lead to a decrease in your cardiac output, and that could lead to a decrease in perfusion. And we know kidneys like perfusion. Kidneys like fluids, kidneys like perfusion. Kidneys. And then last one is hypotension. This one, you could just think of it of MAP under 60. An example could be sepsis. And again, don't hyper focus on like this one's hypotension, this one's hypoperfusion. Just keep in mind the overall picture. The overall picture here is perfusion based things. Fluids affect perfusion. Your heart function affects perfusion. Your the way that your MAP is a sign of affected perfusion. Being hypotensive for too long can lead to all of this stuff happening here. And again, this is a pre-renal, so this typically will not come with permanent damage. This can be fixed. It's when it becomes intrarenal that it really causes the long-term issues. So this is where someone can get an AKI, get rehydrated, have their functions be fixed, and then make a full recovery with no deficits versus letting it get to intrarenal. You recover, but now your kidneys aren't working as good. Maybe now you have chronic kidney disease. So all the things to think about there. So some of the things that could lead directly to intrarenal or lead up to intrarenal: nephrotoxic agents, so anything that negatively is toxic to the kidneys. Things like antibiotics. So that's one of the things that you've got to start really associating with your antibiotics, is the effect on kidney function. Sometimes liver function too, or primarily liver function, but for the most part, your kidneys will be the main thing affected by antibiotics. Think about your vancomycins, the vancomycin, things that end in mycin, those definitely affect your kidney function. NSAIDs, we've learned that they affect your kidney function, your ibuprofens, your ketorolac. IV contrast is nephrotoxic. Hence why you gotta flush it out, or you gotta be really careful with the kidney patients with this. And then also sometimes they just cause they'll cause direct damage to the kidneys. So that's when it can become an intrarenal issue. or just from worsening pre-renal conditions, so a worsening in all of these. And this is why I said kind of think of it as a big picture. You could have this, right? You can have this hypovolemia, and usually the hypovolemia will lead to the hypotension, and the hypotension, that MAP under 60, will then go into this. If you have that MAP under 60 for too long, kind of like an MI, or an MI, if it's not fixed for quickly enough, it leads to permanent heart damage. Same idea. If your MAP is too low, you have permanent kidney damage. So an AKI is almost like a kidney version of an MI, if you want to think of it like that. And then for your post-renal, like I said, this one's more like indirect. This one's more due to obstruction, backing up of urine into the kidneys. So this can be due to maybe strictures, kidney stones, tumors, and this backing up of urine into the kidneys leads to what they call it hydronephrosis. So that's fluid slash urine back up in the kidneys, and that causes damage. Okay. Um, did they ever go over the ratios, the BUN creatinine ratios in your lecture discussion, or any mention of it whatsoever? This one is 20 to 1. So did they go over it, or did you like did you do your own research, Alex? But yeah, so the pre-renal ratio, and it's not like exact. It would be more like it's kind of like the trend towards it. So a BUN creatinine ratio approaching 20 to 1 or more. So the idea would be you literally take your BUN divided by your creatinine number, and the closer you are to this 20 to 1, closer you are to 20 to 1, uh, that would be a sign of more pre-renal versus intrarenal, which is a BUN creatinine that's approaching a 10 to 1 ratio or lower. So, um, can you guys come up with some numbers that you think would kind of fit into one or the other categories? And then if you could, if you're thinking about how these ratios approach these numbers, do you see the pattern do you see the pattern? Like what do you see? What do you notice is increasing more, or what do you notice about it when you're trying to come up with these numbers? That is exactly correct, Alex. So the basic idea is for you to get this 20 to 1 ratio or higher, that is requiring a higher BUN and not so much a higher creatinine. So a creatinine that's not on the higher end, but a BUN that's on the higher end. While for intrarenal, you're seeing a BUN that's probably still high, but your creatinine that's really high. Because to have this 10 to 1, that means that that bottom number is pretty big to make it a lower number. And if you guys recall from all the way back up here, or wherever the diagnostics part is, right here, the creatinine is more indicative of kidney function, while your BUN is more indicative of your hydration level. It's not necessarily a sign of impaired kidneys. It's your creatinine levels that are more indicative. So in this ratio, you would have a high BUN with a possibly normal creatinine or maybe a slightly abnormal creatinine. So you're seeing that in that scenario, the kidneys aren't quite as impaired as in an intrarenal, which we know is permanent damage. You're gonna have this creatinine ratio be super high. Maybe like the upper level of normal of creatinine is 1.1. You might be seeing like creatinine 4 point something. Creatinine uh uh maybe up to 7. That's the highest that Kaylin has ever seen. I'm not sure what the highest I've ever seen is, but I think the 4 is the highest I've seen. She's seen 7, creatinine of 7. So do you guys kind of see that pattern there? And you guys can kind of see how that applies to what we learned up above about creatinine and BUN and how it aligns with the idea of intrarenal is permanent, pre-renal is not necessarily permanent, and creatinine is the bigger indicator. And in intrarenal ratio, the creatinine is high, like really high for it to get to this number. So that's the general idea. Now, when you're in clinical, you probably won't see something like this unless you are on a higher acuity floor or just someone that has a really high or really poor kidney function. So the average Joe is not really gonna be going through all this, but yeah, I just wanted you guys to kind of notice that pattern there. Um, and then I will throw this in. So some of the general assessments, you want to assess those at risk. Look for the 3 H's. Uh, do their eyes and nose. People that take diuretics, they're losing fluids, they're losing electrolytes. The diuretics, they directly affect the kidneys because that's how diuretics work. They directly tell the kidneys absorb less sodium so that um, the water follows the sodium that's exiting, and you get rid of more water. So then that's affecting the kidneys. Someone that's MPO is not getting any fluids. Granted, they could be on IV fluids, but still, nephrotoxic agents and an obstruction of urine flow. Um, and yeah, and then for your labs here, we've pretty much talked about everything here. So I will just copy paste here. So we said high BUN and creatinine for those with AKI, high potassium, low sodium, high magnesium, low vitamin D, but again, don't focus on that one as much. High phosphorus, low calcium because it's inverted with phosphorus, etc. Uh, yeah, low RBC or NH&H, they have anemia. Probably a little bit less with acute kidney injury because it's acute, but you could have acute anemia. But this is especially the case for those with chronic kidney disease. And then possibly metabolic acidosis. And if I recall, Nicole also like mentioned like ABG as a possibility for the diagnostic. So if it's really that bad, you can get an ABG, determine the metabolic acidosis. Additionally, the anion gap that we talked about last week could be a possibility as well. Okay. Any questions on what we've talked about so far? Is it making sense what we discussed, the pre-renal versus intrarenal. Yeah, awesome. Yeah, so which one do you think is more of a problem, pre-renal or intrarenal? Yeah, exactly. Let's see. So, what do you guys know about the management for in AKI? Like, what did they go over? And then I'll fill in any blanks, or if they didn't go over it at all for some reason, I'll just go over it all. Or take some guesses because you guys are smart and you're probably right 90% of the time on whatever your guess is. So, okay, yeah, we got a few good ones. If anyone spoke, I actually went to put my plate away, so I didn't hear it if someone spoke. But so we got strict eyes and nose, 100%. Fluid restriction. Uh, yeah, that's also true. It's just important. It's actually it's a really difficult balance because these people have overload, but at the same time, if they don't get enough fluids, it could get worse. So it's very difficult balance, and it's very difficult. Safety precautions, like general low sodium diet because it'd be like yeah that and again that's another one that's difficult because they're if they're on a low sodium diet, remember that they're already hyponatremic. So it's kind of difficult because you want to limit sodium to decrease some of the overload. But the sodium's already low, so it's a difficult balance. Although it's also true that if you improve that overload, the sodium will go back up a bit because it's not necessarily that the raw number, like the pure raw number is low. It's that it's diluted. So it's like you have a cup of water and you put a tablespoon of salt and then you take that water and then you add another cup of water in there and then it's considerably less salty, but the same amount of salt is in there. IV fluids depending on the type. Yeah, so yeah, that technically correct. Yeah, on the diuretics. So the diuretics is an interesting one. You could say they call it like you could call it like tickling the kidneys. So they might do like a low dose LASIK to try to have it take effect. Yeah, but you definitely still start with the fluids first because again your kidneys need fluids, and I know it's kind of intuitive because they're fluid overloaded, but that's kind of what I mentioned about it being like a really difficult thing to manage because it's like this person's overloaded, but they need fluids, right? So they're overloaded, but they also need fluids because they need kidney function to work. And then they need fluids, but they also might need some diuretics to try to get the kidneys to respond to something. Because remember, the diuretics directly affect the kidneys. They tell the kidneys to do this. So it's to stimulate the kidneys. Low protein diet, yeah, for kidney patients. So I'll put down some of the. Mhm. Okay, so here's what we got here. We got the monitor the fluid balances. So they say daily weights is a good way to measure the eyes and nose or the changes in fluid balance. So for heart patients, daily weights to see if there's been like a lot of swelling. Same thing with the kidney patients. How bad is their fluid volume overload? Are they losing? Are they gaining? Daily weights can be good for that. Strict eyes and nose. They can get fluids, so fluid bolus if they if that fluid bolus works, it's a sign that it could be a pre-renal cause. Yeah, aka they're dehydrated, their fluid volume, basically the three H's. So, and remember with acute kidney injury, they don't necessarily have to have an underlying kidney condition. So in this scenario, they might not be overloaded from the beginning. So they might just be like someone that had like something else happen. They have a kidney injury. Like one of the possible causes was trauma, for example. So trauma, they were bleeding out a lot and then developed an AKI because they went into hypovolemic shock for a bit. Um, so they might not be overloaded before their acute kidney injury started. But the idea of the bolus is again just to see if it works. So they call this being responsive versus unresponsive to fluids. So if they are responsive, it could be pre-renal cause, and then that's easier to manage because we can regulate the MAP, we can get their perfusion back on track, we can help with their heart, we can help with the volemia. If they're unresponsive, that could be a sign of intrarenal because now it's like a deep. It's not something you can just fix by fixing the volume. Now it's an issue with their actual uh, kidneys, their actual nephrons, and it's a lot harder to deal with. Like we talked about, the diuretics, IV push Lasix to stimulate the kidneys, and this is typically done for intrarenal in hopes that it will just work. In hopes that something it'll just work. Just a nice little hope. Uh, and then something that they don't really do anymore, but older doctors might still do it, is low dose dopamine. In theory, it can vasodilate the renal artery and improve renal perfusion, which would then help to fix that renal function. But this is not really largely supported by uh, improved outcomes, so it's not really done anymore. It's not really a thing anymore. But some people still do it, so it's just worth mentioning. And then lastly, the um, calcium channel blockers and ACE inhibitors can be used for blood pressure if they are starting to get overloaded and having hypertension. But it can also help to reduce proteinuria. So sometimes the kidney patients, if they actually, more so for the chronic kidney disease than the acute kidney injury, because this is hopefully just a temporary issues with their kidneys and then they go back to normal. While the chronic kidney disease people, they're long term, they're going to deal with this kind of stuff. They'll be on multiple blood pressure medications. And sometimes, like when you think about like ACE inhibitors, we know ACE inhibitors can increase their potassium, which is something that's already an issue with renal patients. But because it can help to reduce some of that built up excess protein, it's still done. So it'd be like ACE inhibitors, maybe some beta blockers with the diuretic. So like multiple, maybe some clonidine. So multiple antihypertensives all at the same time for the for like a really poor renal patient. Um, so just kind of all that stuff in mind. Did they go over the different stages of AKI? Do you guys know anything about the stages of AKI, or should I just go fully over it? You can kind of take a guess just based on the names, though. So oliguric, meaning the stage of AKI where their kidneys are not working too hot and they're making a very low amount of urine. So this is the kind of stuff that you would assess for here. So that's a lot, I know. We're assessing for that minimum a urine output, like I talked about, the 0.5 to 1 ml per kilogram per hour, or they will have less than 400 ml in a 24-hour period. They're gonna have, you're gonna be assessing their BUN creatinine ratio, and this is, and oliguric is the first stage, so this would be like the very beginning of it. So if they are in that pre-renal BUN creatinine ratio, the fluids, you're gonna want to give them fluids. If they are in that pre-renal stage, again, you're gonna try that IV Lasix to tickle the kidneys. Sometimes you'll see the low dose dopamine. And if they're not responding to treatment at this stage, these are some of the things, and you can use this acronym. It's all the vowels. Um, for the response to treatment. Sorry, if the treatment's not working, some of the things that can come from it. So acidosis, like we talked about, your kidneys don't work. Acid-base regulation is poor. Acidosis. If your kidney function's not working, then you have the electrolyte imbalances that we mentioned. If your kidneys aren't working, it's also not getting rid of waste products. You're at risk for medication intoxication, medication toxicity. Kidneys aren't working, you're not getting rid of urine. So you have overload, and if you're not making urine, you're not getting rid of uremia or uric acid, so you have uremia, so uric acid in the blood, which could lead to things like confusion, altered level of consciousness, similar to how a liver patient could have confusion due to ammonia buildup. And I know you guys probably haven't gone over liver yet, but if you've seen a liver patient, that might be something you've seen before, is like ammonia levels. But so again, if they are at risk of developing fluid volume overload, you want to be assessing the lung sounds, seeing if they have all of these signs of fluid volume overload, basically. But the most important one is going to be your lung sounds, because if they're developing fluid in the lungs, then they're not breathing, and that's bad. That's one of your ABCs, so that makes sense. Something that could be done with their UA would be the specific gravity of the urine. So when they're pre-renal, so when they're in this AKI state and they're pre-renal, their urine specific gravity will be really high, showing that it's concentrated, which makes sense. They're oliguric, meaning they're not making that much urine, and it's concentrated because whatever waste product is being removed is a lot. It's a lot of waste product in a small amount of urine, so dark urine, very concentrated. Now, if they have intrarenal, and this is marked as this teal color because it's a little extra information, it's not likely to be tested on, but it's kind of cool. Very specifically, if they have a lot of direct kidney damage, your specific gravity could be this very specific 1.01 number. And the reasoning for this, that this is the specific gravity of plasma. So your kidneys reabsorb water, reabsorb fluid, uh, to concentrate the urine. if you have such poor kidney damage or such bad kidney damage, your kidneys are just unable to concentrate urine or act upon anything. So this specific gravity of 1.01 is a sign that your kidney literally didn't do anything to the stuff that's coming down that it normally filters out some stuff. It literally took no action on it. This is just the specific gravity of your plasma with no action taken upon it because your kidneys uh are that damaged or that internally impaired at the moment. So if this is happening, that intrarenal is very likely gonna become a chronic kidney disease after it's managed. Because at the moment, those kidneys are literally not doing anything. Okay? So the idea for here would be giving fluids. If they're pre-renal, you're gonna be praying and also trying to stimulate the kidneys into working. But otherwise, you're really gonna be focusing on the complications. You're gonna be focusing on giving them fluids, but then also making sure you don't go too far. They're gonna be maybe overloaded, but you also have no real choice. You do have to give them fluids, but then you have to make sure that they're not getting so overloaded that they have that they're drowning. They're drowning with the crackles throughout the lungs and all that stuff. Okay, does that make sense for the stage of AKI? So initially, kidneys are very damaged, or kidneys are impaired. So the kidney functions, the normal kidney functions aren't being done. So you want to make the kidneys work. So you give them fluids, especially because a large part of the thing that causes the AKI, if we go back up, the pre-renal, it includes hypovolemia, hypoperfusion, and hypotension. So giving fluids makes sense. But because it's impaired kidneys, that means you could be it could lead to overload. So you have to watch out for adventitious lung sounds. You have to watch out for all that stuff, the overload, things that go wrong with overload. You have to watch out for the complication of having impaired kidneys, which includes all the stuff listed here, the high potassium, the low sodium, the high magnesium, etc. And then uh, once this phase is done, you go into what's called the diuretic phase. So this is a sign that the kidney is healing. It's essentially like the kidney the kidney was asleep and then it woke up and now it's trying to compensate for everything it missed out on. So now the kidney is making a lot of urine, but it's still a little weak. So it's not really able to concentrate the urine very well. But there will be a lot of urine output. So it's a sign that the kidney is healing. There will be a lot of urine output, but it might not be well concentrated. So it's a good quantity but poor quality. And you could also see an uh initial rise in creatinine as at the moment your kidney's not concentrating well. So your creatinine might continue to go up before it goes down. But then over time, that creatinine is going to start to go down as the kidney starts to be able to concentrate urine better. So because now you're in this phase where you're getting rid of a lot of fluid, now you have the risk of the opposite of dehydration now because the urine output is so high. But you also don't want to go back and get another kidney injury. So this is that phase of the kidney injury where now you're giving them a lot of fluids to make up for the diuretic phase of an AKI. And then also keep in mind though that someone could get an AKI on top of on top of having chronic kidney disease, kind of like that patient I mentioned before. So someone that already has chronic kidney disease having an AKI on top of it really goes uh into like this weird, very difficult to manage scenario where you have to give them a lot of fluids to make up for the diuretic phase, but at the same time, giving them a lot of fluids could also make them drown on their lung sounds because they could then start retaining that fluid where they shouldn't be retaining the fluid and have those issues. So I had a patient during my preceptorship where that's the exact same thing that's basically what happened. She had chronic kidney disease. She had a history of heart failure. She was already overloaded, but she had an AKI on top of her CKD. Uh, and she was in the diuretic phase. So she was getting, I think, maybe like 75 ml per hour normal saline um, to make up for the diuretic phase. However, something that my nurse and I noticed was that her urine output wasn't really indicative of the diuretic phase. It looked a bit closer to what would be expected, like a normal urine output. And the patient was developing crackles in their lungs and they had weeping edema, meaning that they have edema and their edema is literally like leaking fluid. So that's when made a call to the nephrologist to see if maybe we should discontinue the fluids or decrease the fluids or do something about the fluids. Uh, and that's kind of how that went. So that's kind of like where your job is because the doctor's not in there with the patient. So that's kind of where they prescribe the fluids for the diuretic phase or for the diuretic phase. So now it's up to you to be vigilant and see do they actually still need those fluids? Um, do they have those lung sounds? So that's why it's important, right? It's important to do your assessment, uh, and then when you get really comfortable, think about what you're doing, which is easier said than done because there's so much stuff going on when you're working that stuff slips through the cracks. It's very easy to just be task oriented and just do what's due on your mark. But this is kind of where the thinking part comes in, where like you caught the lung sounds. You're the one nurse on your floor that actually brings their stethoscope. Um, you listen to the lung sounds. You notice that their urine output didn't match their stage anymore. So you needed to call the doctor to make an adjustment. So that's kind of where the nurse comes in. That's your job as a nurse to make those notice those trends, basically. Okay. And then the recovery phase is just that gradual return back to normal. And it's going to be over time. So it could be out of the diuretic phase, like I believe that patient was, and going back to that recovery. And then that's when you have to make those adjustments to the fluids and whatnot. Any questions on AKI? Because I know that was a lot. Do you guys see how do you guys see how I think having the background on the kidneys or the overall picture kind of helps with the AKI? You kind of see what's important with the kidneys, what goes wrong with the kidneys when they're not good, and you can kind of see how that's exacerbated in this condition. So for this one, this is one where 100% having some of that knowledge on how the kidneys works helps a lot. Uh, Not everything is like that. Like for example, Kaylin. Kaylin isn't much of a patho person. You don't, like I said, you don't, but she's very good at application. She's very good at just like this is what I need to know, and what this is what I need to know, and this is like I don't maybe she doesn't know the exact reason for like why this happens and this happens, but she knows what's important
Yeah, so
and
don't ask me the patho questions, ask him. That's all I gotta say.
right. But she knows what's important and kind of don't fall into the hole where you feel like you need to know the deep patho because you don't have to. You just have to know the application, which is again easier said than done. As for me, I'm a lot better at theory than I am at application, and that's okay. It's a slow process of experience having that experience going through it, and then that's when it sticks for me versus maybe I know the deep patho, but at the time because I'm up, I'm doing things, there's so much going on, I don't think about some of the stuff that I know in theory. So for me, having to experience that allows me to make those connections in my brain. But yeah, that's but in this scenario, it does help to kind of have that base knowledge, but you also don't need to hyper focus on any specifics. Please don't, in fact, please don't hyper focus on the hyper specifics. Just really focus on the big picture, like Kaylin does. She focuses on the big picture and she applies it really well. Okay. So then, chronic kidney disease. The good thing is, now that you have all this base knowledge, chronic kidney disease is essentially going to be the exact same um, right here. Like literally everything that we've talked about for abnormal kidney, all of that applies to chronic kidney disease. Now it's just a long-term chronic thing. So it's a progressive and it's irreversible destruction of the kidneys and nephrons. And the manifestation and assessments, exactly the same as we've already discussed. It doesn't have the stages. The stages of AKI is the one thing that doesn't apply to that. But everything else that you see here, like the labs, all the same. Except now it's chronic as opposed to happening acutely and then able to recover is all chronic. So everything you've already learned, it's already applicable. You already can apply it to this. So the stages of CKD instead is just kind of based on it's just based on your GFR, and there are a few nuances with it, but for the most part, you really don't. Even like all you have to really know is one is the least bad, four is the second to worst, and then end stage is end stage. So that's the absolute worst. You really don't have to differentiate. Like you don't have to hard know this. That's for the nephrologist to know. And there are some like there's CKD and there's like A and B. You really don't stress over that. At worst, if you see that at work and you're curious, you could just Google it and you're good. You really don't need to hard. Yeah. So just keep that in mind. Just look it up. Um, but yeah, you don't have to hard memorize any of that. And then we mentioned the manifestations assessments basically the same. Some of the differences, let's see. Little tip for stages start from stage 5, 15, 15, 30 as you go up. Okay, sure. Oh, okay. For like the GFRs, huh? And then also keep in mind, this is GFR and not EGFR. So going back up to the labs, the GFR, the actual true GFR is the creatinine clearance. The eGFR that you see on BMPs is an estimate. So all those, everything based on GFR is the creatinine clearance. Okay. And then the management is where it gets a little bit different. And I like this, I like these pictures, so I'll put it in here. So here's a picture. Again, don't hard memorize anything, just kind of get the general idea. And then the management, it's going to be a lot of the stuff that it's going to be a lot of what we talked about with a few extra things added because now it's chronic. So now you have a lot of long-term buildup of waste that you have to manage. So here, the antihypertensive medications, they're going to be on multiple at once. Like I said, they could be on lisinopril with some Lasix, with metoprolol, and clonidine, all at once because their blood pressure is ridiculously high, or it's just not affected very well by by a single med. They need multiple meds at once to manage it. The erythropoietin, because remember that the kidneys help to make erythropoietin, uh, and so they can get epogen, synthetic erythropoietin, to improve their anemia. They could be getting vitamin D supplementation because their kidneys don't make enough, uh, they don't activate the vitamin D as well. Doesn't activate the vitamin D as well, which means that their calcium intake is worse. So some vitamin D to help improve their calcium because now they're chronically going to be low on calcium. Maybe some iron to treat anemia. And some diuretics because again, they're fluid volume overloaded. So you're managing a chronic fluid retention now. So like I said, they could be on Lasix. Another benefit of the diuretics is that it can help waste some of that potassium and magnesium and phosphate. Uh, Phosphate binders. So some meds that you might see if you have a kidney patient, and they do have a lot of meds, is going to be calcium acetate, otherwise known as Foslo. So this is this phosphate binder needs to be taken with food. So it will the Foslo will bind to the phosphate in the food and decrease some of the absorption with it. Another thing to note is when somebody with chronic kidney disease, they can be very itchy. So skin, it can be they have a lot of itchiness, like pruritus. Um, that could be caused by the. Hello, can you guys hear me? Okay, recorded again. That's good. Okay. Let me go back. Sorry about that. My internet. So sorry about that. My internet was doing its thing. Okay. So what was the last thing you guys heard? Was it about phosphate binders still? Okay. So calcium acetate, phosphate, you got to take with food. It will help to bind any phosphate that's with the food to prevent absorption. And then going up here, one of the things that people with CKD can have is itchy skin. And that itchiness can come from phosphate buildup. It can also come, well, it comes from phosphate buildup. Allopurinol can also, sorry, not allopurinol, the uric acid buildup can also make you itchy. So the phosphate binders can help decrease some of the itchiness. Something that I found interesting is that I've seen some patients that are on SSRIs, not even for depression or anxiety, but sometimes like citalopram can actually help decrease some of the itchiness in in people with chronic kidney disease, which is interesting. Because I remember having a kidney patient that had citalopram. They told me that uh they did not have like depression or kidneys or depression or anxiety or anything. Um,
So it has a possible function of helping with that. Okay. Look, we mentioned that if your BUN goes up, that's your uric acid, your urea nitrogen. So if that acid, uric acid is building up, allopurinol, if you've heard of this one before, I feel like it comes up every once in a while, is to help decrease the uric acid buildup. Allopurinol is used for people with gout because that's okay. Let's try this again. So allopurinol, uric acid buildup helps decrease the urea. And then the renal diet is horrible. It's a protein restriction, sodium restriction, which again is very nuanced because you don't want too little sodium because then you're hyponatremic. Restriction of the electrolytes that build up, water restriction, which is again pretty difficult because you also don't want too little fluid, or you could develop AKI on top of your CKD. So kidney issues are honestly terrible. The renal diet is awful. Imagine having to do all of these things. It's horrible. Hence why a lot of people are non-compliant. And then that ends up leading to worsening of their kidneys. Maybe they have to go on dialysis. But there's a reason why a lot of kidney patients are non-compliant, and it's because it's a lot of medications. The appropriate diet for it is horrible. A lot of stuff like that. They can also be at a risk of low blood sugars because the insulin is held on longer in the body because the kidneys aren't able to properly waste it. And then some of the things to avoid include nephrotoxic drugs, makes sense, right? Decrease in your NSAIDs and stuff like that. Avoid antacids because they have magnesium in them. And then Demerol, which is a opioid. I don't think it's very commonly used anymore because the way the body breaks it down, the metabolized product that comes out when your body metabolizes it is toxic. And so if your body has a hard time getting rid of things that your liver breaks down, it's gonna be the toxic buildup is gonna get worse. So Demerol is an opioid. I've only really seen Demerol in labor and delivery, to be honest. If I recall, it helps with some of the shakiness that can occur rather than being used for pain in um that field. And then assessing for complications due to medication buildup. Okay. Okay, any questions on CKD and some of the meds? Okay. And then last, we can go over dialysis. We're almost done, like very, very close to done. So dialysis, I have the definition written here. Just a way to filter out your blood because your kidneys aren't able to do that and get rid of some of the waste. Fix your electrolyte imbalances. So when is it typically done? We'll just try to get through it just because I don't know how long my internet's gonna last. But typically done, usually later stage chronic kidney disease, end stage renal disease. A lot of nephrologists, even on end stage, will try their best to not put you on dialysis until every last nephron is dead. They'll try their best to try to not put you on dialysis. Maybe if you're acutely, or if your creatinine's this bad, or if you have acutely high hyperkalemia with EKG changes, they'll just do uh, just like a dialysis because It's not to stabilize because this is not consistent with life.
It's not consistent with a long.
Yeah. So the main types of dialysis is hemodialysis and peritoneal dialysis. So hemodialysis, it's going to go through a filter machine. It's going to take a few hours, and one of the main things about these people is that they have what's called an AB fistula or a graft. If you've ever seen it, oh wow, look at that. That's crazy. That's a very engorged one, but something that should be given to you in report is where their AB fistula is. But obviously, if not, you could always ask the patient, and it'll be pretty obvious. Hopefully it won't look like anything like this. God damn. But it'll be poking out. There should be a sign in the room that says no blood pressure or labs drawn on that arm because you want to maintain the patency of that graft. So some of the things you're doing when somebody has a fistula or a graft, you're not taking blood pressure or lab draws on that arm. You're watching out for clotting or infection, and you can see what can happen when it's not patent. It's clotted or there's something going on here. Exactly, Nicole. Yeah. So you're gonna wanna for the assessment part, you're gonna wanna palpate for the thrill, which is the vibration, and you wanna hear the bruit. So you'll hear a whooshing sound, whoosh, 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 like that. So it'll be very loud. That's a sign that it is working well. Now, if you hear that when you're listening to the heart, that's not a good thing. But for this, it's good. So this is a sign of assessment for good patency. Okay. So this is important. It's like comes pre-highlighted here, but this is very important for when the patient is getting dialysis. Is one, the patient does not have to be MPO. We can do AKI checks and give insulin, but the most important thing is that you're going to be holding your blood pressure medications because after dialysis, their blood pressure will be more stable because you filtered out a lot of a lot of the waste product. You filtered out some of the fluid. So after someone gets dialysis, the dialysis nurse will tell you how much was taken out, how much liters was taken out. So it's important for you to hold blood pressure medications because you do not want them to crash. Yeah. In general, you probably want to hold most things because a lot of medications are going to be water soluble. And so if you give them their meds and then like, for example, like their supplementation, vitamin supplementation and stuff, you're literally just going to filter them out through the dialysis. So there was no point. But you definitely want to keep in mind dialysis hold BP medication. Okay. So some of the complications that could occur is issues with your fluid balance. You're literally getting rid of some fluid. You are messing around with the electrolytes. You're doing all that stuff. So what is very important is to get a weight. So remember we talked about how the daily weights are really important for these type of patients because you want to see same thing with their heart failure patients because you get to see any changes in their fluid balance, if they're becoming too overloaded, if how much fluid that they lose. So they call it a wet and a dry weight. So they're wet before dialysis because they're overloaded, and then they're dry after dialysis because you drained some, you got rid of some stuff. And something to keep in mind is it's easier if they give it to you in kilograms straight up because 1 kilogram is equal to 1 liter of fluid loss. So that's how that kind of gets calculated. But if it's in pounds, you'll have to convert from pounds to kilograms. So 2.2 pounds is equal to a kilogram, which is then equal to 1 liter of fluid. You'll want to do your vital signs before and after, although I believe that will probably be done by the dialysis nurse. Yeah. So you can obtain the baseline and determine if you need to stabilize the blood pressure while they're getting dialysis. Because you're getting rid of fluid and electrolytes, there's a chance that that rapid change in fluid shifts, rapid change in electrolytes leads to what's called the disequilibrium syndrome, which can lead to altered level of consciousness, nausea, vomiting, headaches, restlessness, seizures, increased intracranial pressure. So that big shift in fluids can again cause fluid to go into the nerve cells, into the brain cells, call alter level of consciousness, cause extra pressure in the head. And if this occurs, this was call the rapid response, let the doctor know, and then do some of the basic things to do anytime this happens. Head of the bed up, O2 if necessary, vital signs. Another possible complication is going to be blood loss. This person, again, is at a risk of clotting, and you don't want to, you don't want to clot up that graft. So this patient could be. It's honestly it could. It's from what I heard, it's more of a could rather than a should all the time. But a heparin drip to prevent clotting during dialysis. So if they're on a heparin drip, they're at risk of bleeding. So you also gotta assess all that. And then infection because you're accessing an internal site. Okay, so your key takeaways here is going to be the assessment of patency. You're going to want to make sure you're keeping in mind the complications. Don't ruin the patency of the graft. You 100% always want to hold the blood pressure meds, and you want to watch out for changes in fluid and electrolytes. So you want to know what their weight before and after dialysis is. You want to know if they're having these symptoms of disequilibrium syndrome, which is again a rapid, super fast change in their electrolytes and fluids due to dialysis. And then there's also peritoneal dialysis. This one is instead of having their blood basically removed and then filtered and then put back in, peritoneal dialysis is actually going to be done through their peritoneal, which is that space in the abdomen. And you're going to have the exchange go on like that. The advantage of a peritoneal dialysis versus a hemodialysis, the hemodialysis, you're kind of stuck there. With your peritoneal dialysis, you could be a little bit more independent. So this person has, okay. So peritoneal dialysis, you can be a bit more independent. As you can see, this person's reading. They have their IV pole with their dialysis solution. They have their whole set up, connected to their peritoneal area, and then they have a draining bag with after it's gone in, it comes out. So the way it works is you have this dialysis solution that goes in, because fluids want to go to where there's more solute. This dialysis solution is prepared specifically for this patient at the current time, so that it will cause a kind of like a perfect balance of movement out from the peritoneal area out into the draining bag. So it's calculated so it causes a shift of fluids that way. You don't need to know the specifics of all that. Just kind of know that that's how it works. Solution goes in. The waste products and fluids exchange because of the way this is set up so that the gradients kind of go in the way you want and then gets drained out. And you're a bit more independent because you can just have your IV pole around and you can go around and do stuff. Okay. You'll still want to do a dry versus wet weight. You still want to do the vital signs. You want to be aseptic because you don't want to get infection. Remember, if you have an infection in your peritoneal, peritonitis, that can be really, really bad. That area is really big. So risk of peritonitis, that's important. And one of the things that you want to monitor, if you take a look at here, some of the way that the solution is going to work to get rid of stuff is actually based on glucose. So this bag is set up in a way that it contains glucose, and that is part of the solute that causes the fluid shifts over from the body over to the draining bag. So because you're putting glucose into the peritoneal, you want to monitor the blood sugar because you could be doing too much and then they go hyperglycemic just from the way that the whole system works. So again, the complications, like I mentioned, peritonitis, so a firm abdomen, board-like distended abdomen, painful. The key thing, you will see cloudy and frothy solution from the draining bag. So anytime you see cloudy, cloudy's not good, right? Oops. Again, because this whole thing functions through glucose concentrations, monitor their blood sugar, give insulin if needed, which same thing with the hemodialysis is no issue. We can do that as well with that one. If they have abdominal pain, and this could be a question that gets asked, like what do you do if someone's getting peritoneal dialysis and they have some abdominal pain? This could be related to either the flow. So you notice here that this transfer set has like a little clamp so they can adjust it. Could be related to how much is coming in, or it could be related to their position. So some adjustment could be done, repositioning, maybe adjusting the clamp a little bit. Is there any issues with some of the stuff? There's not enough stuff coming out compared to what's coming in. So if you're getting a certain amount of dialysis solution in and you're really not getting too much out of the draining bag, again, it's possible that it might be kinked. So you want to check your tubings, reposition the patient to relieve pressure. So in general, with the peritoneal questions you might get, a lot of that ends up being repositioning. So it's always like least invasive. So try repositioning first. If you do have these symptoms though, that's when it becomes a really big problem because peritonitis is could be really life-threatening. And that's pretty much it. That's pretty much it for both of these for this whole topic section. Is there any questions on anything we've talked about prior? Because I know it's a lot of content. Any questions whatsoever? Okay, if there's no questions, I'll stop the recording.